Hello, welcome to my monthly message for July. The first thing I want to talk about this month is the financial position. You probably know that the financial position across the whole NHS is really tight. We are no different. One of the main areas of increased spend that we have in the Trust is on agency staff. We spend a lot of money on agency covering admin and clerical posts. One of the reasons for this is that a number of posts have been frozen for quite some time. We've lifted this freeze, and so these posts need to be recruited into. If you are a manager, you need to talk to staff about possibly joining our Trust Bank. To support managers in this, we're going to have a number of recruitment days. If you have admin posts that you need to recruit to, can you please contact the recruitment team in HR? The details will be on your screen now. There are obviously a number of other posts across the Trust which are vacant that we need to continue to recruit into. We've been really successful at recruiting more nursing staff over the last 5 months. Our vacancy rate has come down now to about 18%. We need to continue on that. So you will see more posts being recruited to and less money being spent on bank and agency. In my last message I spoke to you about the CQC report that we've had and some of the improvements that they said that we needed to make. One of them was about supervision. So we've launched a new supervision policy. Details are on the intranet. It's really important that people get regular supervision, and this is a joint responsibility. This is a manager and a supervisory responsibility. So can you please make sure that you have supervision regularly? As I say, details are available on the intranet and on Compass. I'm really pleased this month that we've launched our new website. The old website we had was over 10 years old, wasn't very inspiring, lots of words on it, and not the most interesting one to look at, to be honest. So we've now got a new one. It's really good. I'd encourage you to have a look at it. There's lots of information on there, easier to access. There are films, there are interesting articles about people. So please, if you've got time, have a look at this. Feedback is welcome, comments are welcome. You can make those to our comms team. But I think it's worthwhile having a look and just seeing some of the things across the organisation that you may not have known about. This morning we had the CQC Quality Summit. This is a formal meeting where the CQC present back the findings of the inspection that they did with us in March. The summit was attended by over 60 people, stakeholders from CCG, local GPs, local authorities, service users and carers, and some of our own staff. We heard back from the CQC about the many positive things that they found about the Trust. The fact that staff were caring, well motivated, and that they were able to speak up if they had incidents that they needed to raise. They were particularly complimentary about our acute care pathway, the services for people when they're admitted to wards, and that we were the only Trust in London to be rated as good across all of the domains on the acute care pathway. Very good, excellent, considering the pressures that we've had on beds over the last 18 months, and the improvements that we've made on that were really reflected in the CQC report. The CQC are going to come back in September to look at some of the areas where we required improvement, but it will be a very light touch visit. There'll only be a handful of staff coming back. Really confident that we can have shown in September that we've made improvements in the areas that they highlighted. And if we have, they will change the rating. Really confident we will get to good by then. I'd just like to say a final thank you to everyone for all the hard work that they've done, the work that you do day in, day out, that was recognised by the CQC. The film from today's event is available online if you're interested in watching it. So what I'm going to cover is just a bit of an overview of some of the things that we've got in the Trust. What we need to do that we can improve by ourselves within the Trust, but the other things that we need to do together. So we can't do all of this ourselves. We need to work with everyone to be able to do some of the improvement. So I'm going to break them down into those two areas, and then we're going to go on to some of the things around, say, questions and answers. The first thing is just a quite nice infographic, some numbers of our organisation, number of beds, number of staff, the ethnicity, the top left there, 73% of people using our community services said they had a good experience around it. So lots of information there. Just to remind you about our mission, our values, our strategic objectives. Our mission is that we want to be a cost-effective centre of excellence, somewhere where patients want to be treated, where staff want to work and train with us, and stakeholders want to work with us. Our values down the side here. When the CQC came, we talked a lot about this. We've been doing work on this for the last year. And this is not something that Peter and I and the Trust Board have developed. We've done this in partnership. People have developed these. These are values that we've developed with staff. You can see what they are there: respectful, open, collaborative, compassionate and consistent. And they were values that people thought applied to the organisation, should apply to the organisation, and should be followed and should be demonstrated in our day-to-day behaviour, the way that staff behave towards each other, the way that staff interact with service users and carers and stakeholders. And we've gone on from developing those as a set of values to actually embedding those, as I say, in how we work, but things like how we recruit people. So we have a values-based recruitment system now where we test these for people who are coming to work in the organisation to make sure that they have these values. Because we think it's really important that we have people that follow those. We know that by following some of these, we'll get better patient care. So, as Jane and Kevin said, I think there's a lot to be proud of. Some really good feedback. Obviously, some things to improve on, but if I can just dwell on a couple of those things at the time being. And that's, I think it's not just for us in the organisation. This has been done with most people in this room that have contributed to it. Whether it be Nick, Caroline, service user carers, worked with us for many years, who've contributed to how the service has developed, how the organisation is. Martin, who's from Health Watch, Wandsworth, who always holds us to account at board and will come and ask questions. It's by commissioners, it's by our partners in care. We've all done some of this, and I think that, you know, this is not for the services that we think are good. This is a reflection on everyone's contribution to that. So I'd like to say thank you to all people that work with us around that, and that you continue to work with us to keep on improving those. Some of those, I like these things, that there was a healthy culture, that young people and their families are treated as partners in their care. And then significantly about improvements in acute care pathway. We've had a lot of pressure on beds over the last 18 months, but it was really good to see, and as Jane said, I think we still are the only trust in London that is rated good across all of those domains on the acute care pathway. That's despite the massive pressure that we've had and our staff that have pressure on wards day to day. It was good to see that those positive comments. And there's some nice pictures that Ranjit and his team have put together here. But importantly, it's not just things, it's things that this trust has done over the last year. You can see here in the middle, the Drug and Therapeutic Committee were awarded the Team of the Year by the Royal College of Psychiatry. It's a very prestigious award. Carl here, there's others here, Emma as well there. But there's service users on this committee as well, so it really is a team that isn't just about staff looking at how we improve things, but it's a real partnership around things. There's things that we did with ITV about changing minds, about trying to improve reduce stigma, and then the picture down here, this was quite a good thing that we launched this about uplifting images, and it was a competition, local photography based competition about who could, some pictures that were really uplifting. There's some of our local MPs on there who were judges. Peter particularly drove this with our comms team, and there's school children there that took part and won awards on that, as well as other amateur photographers. We'll be doing something like that again, so there's just a reflection around some of the things that we do that's just a little bit different. So, okay, right, the recommendations that we've got from the CQC. Just a bit about how we developed it. Again, this wasn't something that we got the report and said, right, okay, let's write an action plan, let's write this. Vanessa, me, exec teams, Emma, others write it. We went out, we've had 7 staff engagement events. We've spoken to staff about what does it say in the CQC report, what can we do to improve on those areas where it's identified that we need to. So we've had a number of open sessions with people where we've got ideas and developed those into realistic plans that we can embed and we can deliver on. They're not in a separate action plan, it's in our day-to-day business. So it's part of people's objectives, it's part of service directors here, it's part of clinicians who are in this room. We monthly look at some of these things. This is about everyone's business. It's on our risk register, so we haven't said a separate document, there's the plan, and kept it as a side. It's about how we work to, in our day-to-day business to continue to improve quality. I'm going to cover three areas. The last one, medication, transport and storage. That bag says it all really. We've done that. We've got locks on bags. The finding was some of our staff were going out without locked bags and having medication and taking those people up. Everyone's got one of these who transports drugs now, and a combination lock on it. We think that one's been done. I'm not going to highlight on that. So the other ones that we're going to go through is in terms of administration, supervision and reducing restrictive practices. So the first one I'm going to talk about is about administration process, and it sounds pretty simple, but it actually is really important. And this was about, we've been moving to a system slightly different around how do we use some electronic dictation services and transcription so that we're not having people writing letters and then being typed up, all the traditional dictaphones. It's a digital translation service, and it's fair to say we've had a mixed picture. Some areas it worked really well, some areas it didn't, and that's what Jane and her team found when they came. So you'll see a little video about some of the things that we've done around that.
Timely communication is so key, both users, carers, GPs, they all identify the need for us to get our letters out quickly so that medication can be adjusted, that patients' reports can be done. We have struggled with that over time, and I think the new admin review with the centralisation of admin functions so we can cover for leave, sickness and absence is a good way forward. I think particularly exciting is Big Hand, which is an electronic detection system. We went to see it in action in a trust in North England, and they managed to increase clinical productivity by about 30%. Because what we want our clinical staff to be doing is face-to-face clinical contacts. We don't want them doing typing, administrative type functions, and hopefully Big Hand will help us become much more efficient.
It was really good to get the response from CQC around how well we're doing our clinical services, acute care, CAMS, learning disabilities, but we wouldn't be able to run those services without the dedicated support of our admin staff. We've been on a journey with reviewing and modernising our admin services, our support systems for some time. And when CQC came and had a look at what we were doing, we realised we hadn't got it quite right. So what are we doing about it? Well, we've introduced a new structure for our admin staff, a clinical services support manager who will oversee their supervision and make sure that they get the right support right the way across the organisation. We're standardising everything that we do across all of our directorates. We're introducing new technology, Big Hand, auto-transcription, to make our response times quicker, and service users will hear back from us and GPs will hear from us quickly. And finally, we're training everybody in the right skills around customer service and administrative support to make sure that we modernise across the organisation.
So that's what we've done on our admin. I think that says it all really, and I'm clicking here and hoping that this is going to move. There we go. I think Mark and Dawn said some of the things there that have happened, and I'm confident that when you come back, Jane, you will see a difference. And I'm confident that GPs like Phil in Kingston will be seeing that they're getting letters quickly, they are getting things that's out, and the proof of the pudding will really be there, that you will see some of that. The next thing that we focused on is, this is supervision. We know that staff were getting supervision, we weren't recording it as thoroughly as we should do.
So in developing the supervision policy, we try to engage with as many staff as possible from across the trust. So we have a number of listening to action events across all of the sites. We also discussed this at the leadership forum and took in lots of other feedback that we had through listening to action and through supervision itself and the ADRs to make sure we got the policy right. We tried to keep it as simple as possible, and that's meant that we've got some minimum expectations for all staff working in the trust, which is that
every member of staff has supervision every 6 weeks as a minimum, that the supervisor and the supervisee have joint responsibility for supervision, and we've got a standard agenda to ensure that the most important topics are discussed on a regular basis and actions are agreed. We are providing a training programme for supervisors to equip them with the skills to provide supervision in a meaningful way, so that it's not just a two-block exercise. And we're also monitoring compliance with the policy through our dashboards, which will then be monitored up to board level.
Just in terms of the process and staff side being involved, from the meetings that I've attended, looks like you've had full engagement, and it was great to see so many different leads from different professions, psychology, nursing, facilities as well. That was really great. And from a union perspective, obviously we feel that supervision is incredibly important and that staff should embrace it.
My supervisee, she listens to me. I explain my issues to her, and even out of practice basis, clinical issues, she will still find a way to reassure me and to give me advice. Then when it comes to the clinical issues, she will be supportive, and to me, I feel that supervision is very good for me, because all my issues, if some of my issues, if not all, they are, when I identify them, it's sorted.
Supervision is broken down into various components. It's 4 weekly, and it's a space that's always booked in advance. And during supervision, we will look at various areas. The main area is performance and reflective practice. It's about the quality and the quantity. So I think that the quantity is shown in the dashboard, where all these the areas of risk assessments and physical health are being monitored. The main part of performance is the caseload audit, and it's my supervisor will pick one particular case and go through that with a fine-tooth comb. And that will be random. I don't know about who that case will be. And he will look at the care plan, the collaborative crisis plan, physical health, and all the other relevant parts. The supervision also addresses health and wellbeing issues. It gives support, it gives advice, and acknowledgement of achievements, so you know what you're doing right, what you're doing wrong, and it looks at other angles to manage risk. It's an opportunity for me to continue to provide a high quality, safe, effective quality of care.
I can assure you none of those are scripted, honestly. They were what people thought about what they're doing. And just to say that, as I said earlier, supervision was happening. We wanted to make sure that it was absolutely consistent. We've moved it from something which really was we can do this, to a must do. Everybody must do this, must do it every 6 weeks, must record it and show in terms of what's happening with that. So that was our supervision. The next thing is restricted practice, and another very short video that explains some of the things that we've done on restricted practice and improving this.
We have recently set up a restrictive practice group. This is to ensure that as an organisation we are monitoring all forms of restrictive practice that happens across the organisation.
The Progress Board has an action plan to ensure the physical changes that are required in the implementation of the improved practice are in place. The nurses are very caring and have strong relationships with young people, and they seek to develop behaviour plans as part of the care plans, so that when a young person needs an opportunity to calm down, there is a pre-agreed system in place. Clearly, these do reflect restriction of social interaction, and so need monitoring in a different way from how we had done previously.
As a student nurse on currently on placement, I had the opportunity of attending a training session on restrictive practice. For me, it was quite useful because it threw more light on the the use of seclusion out, not to have a situation where patients are unnecessarily excluded from other members from the ward activities. And I've seen a shift, and you realize that patients are operated based on day-to-day, not just day-to-day, time-to-time assessment, and that helps the patient.
I think the most important thing that also came up from the training before me was ensuring that there is clear documentation of why, the rationale behind seclusion. A lot of the time, you ask, the team, you ask yourself, was that necessary? There is a dialogue among the team, between the team members, with this, most important with the patient's involvement. If they really need that seclusion, because the seclusion is a worthwhile payment.
So what we've done, as Sharon has said there, we've got a least restrictive practice group established, reflective development sessions for all staff, and we are monitoring restrictive interventions in all aspects of care. So just some of the things that we think that we need to do together. They're the things that we think that we can do internally. We can solve some of those, sort those issues out. We need to do things together. It requires lots of us who work across mental health in different roles to do some of these. The strategic context, I won't go in a lot of detail around this. There's a strategic context for South West London. There's a bit like most other areas of the country, i.e. there's no money. What are we doing to be able to try and improve care in that environment? The last bit there I think is quite important. What do we do to be able to look at how we can shift the paradigm the other way and look about prevention more, rather than it's what are we providing services, how do we help prevent those? That's within how can we help to support things in primary care, how do we help with employment, in housing, in friendship things, and we know they're the some determinants of good mental health. How do we shift that to, so we're looking at prevention rather than just actually moving on to treatment. Rehabilitation, again, that's something we've got to be able to do with commissioners, we've got to be able to do with stakeholders, with service users, and looking at how do we change the model that we've got. We've got some interesting ideas, we've looked at other places elsewhere, we've got ideas that we can do around that, but we need engagement around that. There's two things that we're doing here around how do we look at some intensive interventions so that patients feel fully engaged, and as I say, transforming this model so we get more of a step down, so it's not seen as it's within hospital. There's a lot more community choices and a lot more community provision. We need to continue in our journey around adult mental health modernisation. These are some of the drivers that we've got: rising demand, financial challenges. Our caseload has come down slightly, but is still higher than it was 2 years ago. And we need to learn from things that go well. We do not have the same system of care in every one of our 5 boroughs. And that's, probably there needs to be differences within care. I think that we need a model that has the same principles, but can be flexible for different areas. So there are different patterns of care in different areas. For example, the different practices within primary care across the boroughs. And so we need to reflect that in the models. But equally, we need to know when things go well. Sutton always comes up as something, when we look at some community services, on some of the indicators that we've got, where we've got average caseload days, Sutton is a better performer. And then length of stay and adult inpatient services, Sutton is a better performer. So how do we look and how do we learn from those across the organisation? These are some of the things that we're doing around adult community care. Ian has been leading a lot of that within the organisation. There's some issues there that we've done on that. And I think we'll get into that within the tables shortly, so I'm not going to dwell on that. So we will get onto that in the sessions that we have following this. So I'm going to finish on just quickly looking in terms of the future of what we're going to do. I think the future is positive around services here. We know that, and I feel like I've been saying this forever now, I've only been here 4 years, but about building new hospitals, and it is going to happen, and it will happen here. It actually is happening in the first phase of it has started within one corner of this site, but we will be building these 2 new hospitals. We'll offer fantastic opportunity to provide the new, really up-to-date services. We've got our architects have developed a fantastic thing, and there's a number of people in this room have used this, where you can put these virtual reality goggles on, and actually see what the services will look like. And we, perhaps at our AGM, I think we may do something where they can show it there. So if people who come to our AGM, there's an incentive fee to be able to see what these new wards will look like. It's really good. You can see, and it will offer fantastic facilities for our inpatient. We need to continue on the improvement of our quality, getting people into employment. Our chairman is leading some of this work across London. We know, as I said earlier, about the importance of employment, and I think that we've got a particularly strong record about how do we help people into employment. We need to take this further. Our Patient Quality Forum has been established. I get positive feedback, and Caroline will tell me around some of that when you know, issues with that. But that's a really positive thing that we developed now. We want to continue and make sure that that works and works well. That's a way of us getting feedback from our service users across the entire patch. Investing in our staff training, as ever, embedding our values, and, as I say, being an employer, a service provider, partner of choice, one that's clinically effective but financially sustainable as well. So that's all from me.